Hello, welcome to this edition of Healthfirst. Today we have with us Dr. John Wideman of Coleman Primary Care Obstetrics and Gynecology, and he will be informing us more about women's health. Stay tuned.
Well, hey, thank y'all for letting me come down today. There's over the last few years, there's been some sort of a lot of confusion, and so about women's health, in particular hormones and hormone therapy. It's unfortunate that a lot of people get a lot of their medical findings from Oprah, but it's good that Oprah's not on the air anymore, and now we got Dr. Oz, and Dr. Oz is a little bit better. And people come in all the time and says, "Well, Dr. Oz says this," and so most of the time Dr. Oz is correct. But just a couple of things that women come in who come in to see me are always asking, like, "Well, what do I need to know about hormones, and are they safe?" Because then it was put out, "Oh, I don't want to take hormones because they cause cancer." Well, no, I wouldn't give you something that's going to give you cancer, I promise. And do I really need to take them? And how long do I have to take them? And so these are the most common questions that women come in and ask me. And so I thought I would try to hit on these things and see. And if y'all have any questions, or if there's anything I can kind of clarify or go into more detail on, I'll be happy to do that. Your body's hormones, I mean, there's many hormones in your body, but the ones that we're talking about as far as hormone replacement goes are estrogen and progesterone. Estrogen is manufactured by your ovaries. The lifespan of the ovary, the average woman goes through menopause at about 51, 52 years old. Now we have a part of life which is called the perimenopause, which is a lot of people think about menopause as a doorway, and you step through the doorway. Well, with the perimenopause, it's more of like a tunnel, and it's kind of a gradual process. And so we'll talk about some more about estrogen. And then progesterone is also manufactured by your ovaries. And women with an intact uterus, when we're talking about hormone replacement, need to have what we call opposed hormones. Estrogen, let me just say, in the past, we used to be very aggressive about putting women on hormones, and said, "Oh, it protects your heart, protects your brain, protects your bones, protects all these things." Well, there's some studies that came out. One was called the HERS study, which is Heart and Estrogen Replacement Study, and the other one was the Women's Health Initiative, WHI. With the results of these studies, even though as flawed as the studies are, come to find out that hormones didn't do everything that we thought they did. There's still a place for hormones, and we're down to really 3 reasons why we give hormone replacement, and that is for the perimenopausal signs and symptoms of hot flushing, dryness, vaginal dryness, we call it urogenital atrophy, and bone changes. The hot flushing, they usually, hot flushing can start anywhere about 75 to 80% of the women going through the perimenopause will experience hot flushing. So that seems to be the biggest complaint that women come in with. The dryness, when they come in and they start complaining about this, then you start asking a few more questions, like, are you having dryness? And what happens is the estrogen receptors in the area become depleted, and the elasticity of the tissue is lost. And so with the dryness and the loss of elasticity, women come in and complain, and they hardly ever say it right out. I have to kind of ask them, "Are you having problems with intercourse?" And they go, "Oh yeah," and so that's a big part of the perimenopause. And then bony changes. By the time you're 19 years old, you've reached your peak of your bone mass, and then by the time you're 30, that bone mass starts to decline, and it declines from age 30 on until the menopause, and then after menopause it's a pretty rapid decline. Estrogen helps your bones hold on to calcium and keeps your bones strong. With bone loss, then we follow something called with a test called a DEXA scan, or a bone scan. And with that bone scan, when we start to get calcium loss in your bones, we get into negative numbers with the bone loss. And when we get to minus 1.5, we call that osteopenia. And then we get to minus 2.5, we call that osteoporosis. And so we use hormone replacement to help your bones hold on to calcium. And this is estrogen. Now, women with, to go back to the beginning, I was saying, women with an intact uterus, estrogen works on the lining of your uterus to cause it to thicken up, of course, in preparation for an egg to come and implant and to carry your pregnancy. Progesterone helps stabilize the lining of the uterus and keeps the uterus from thickening too much. So women with an intact uterus and hormone replacement, we have to oppose the estrogen with the progesterone. If women have had a hysterectomy, we don't have to worry about that, and we don't have to use the progesterone. So some people draw a line of what we call estrogen replacement therapy and then hormone replacement therapy. Hormone replacement therapy meaning estrogen and progesterone together. Y'all, is that okay? Okay. So hormone therapy. The benefits. Why do you even need to do this? Both types of hormone therapy, combined and estrogen only, so combined meaning opposed to estrogen, remain the most effective treatment for symptoms of the perimenopause. Now, we got lots of tools in the toolbox, and you don't have to take hormones. But what seems to be to help with the symptoms the most is giving you back what you don't have, and that is estrogen and progesterone. Both types of hormone therapy help prevent the rapid bone loss that occurs early in menopause. Like I was saying, after 30, it's downhill. After menopause, the perimenopause and menopause, pretty rapid downhill decline. And it's shown to prevent or reduce hip and spine fractures. And that's, when I tell ladies too, I said, we do this to help keep your bones strong, because then what happens is you trip and you fall, you break your hip, you get a hip replacement, and you wind up in a nursing home, and then you die. So we want to prevent that. And low doses of local estrogen help relieve the vaginal dryness and the irritation. So it doesn't have to be a systemic, which means like swallowing a pill or using a patch or anything like that. We can also use a cream directly to the area. There's also a small tablet that comes. It looks like a pen with or a pencil with a little pill on the end of it, and you can insert that and release that pill, and that pill will dissolve and kind of help localized symptoms. So the risks. So outside of Oprah telling everybody hormones cause heart attacks, hormones cause cancer, hormones will kill you, quit taking hormones. Well, Oprah tells 40 million women to quit taking their hormones. Well, who do they call? Well, they don't call Oprah to tell her when they're having problems. They call us. The risks here of combined hormone therapy, specifically a combination of oral, and it's called conjugated equine estrogen, which is Premarin, and a progestin called medroxyprogesterone acetate, is associated with increased risk of stroke, breast cancer, DVT, which is deep vein thrombosis, gallbladder disease, urinary incontinence, and it doesn't prevent heart disease. This is what came out in the HER study, the heart estrogen replacement study, or heart estrogen replacement study. They've since done a follow-up on that study, and they used that study that came out with this data, took women, the average age of the woman in the HER study was 64 years old, so far past the perimenopause, far into menopause. And women who had already had one cardiac event, who had never been on hormones, and they put them on hormones to see if it would prevent a second cardiac event. Well, it didn't. And these women still had heart attacks. Well, they didn't really explain it like that. They just said, oh, we put women on hormones and they had heart attacks, therefore hormones cause heart attacks. That's not exactly how it went. But there is a risk with this. Estrogen-only therapy increases the risk of endometrial cancer. And that's why I'm saying if you still have a uterus, you need to be on opposed estrogen, or estrogen and progesterone together. We don't give unopposed estrogen because of that chronic stimulation to the lining of the uterus and causing, leading to endometrial cancer. And estrogen-only therapy is associated, same thing, increased risk of stroke, gallbladder disease, DVT, urinary incontinence, does not prevent heart disease. So you're saying, then why do I even need to take this? Why am I even taking this? Well, the benefits, the current recommendations. If you currently let's see, did I go too far? Let's see, risks. Oh, benefits, there we go. Okay, let me go back to benefits a little bit. So say, why do I even need to take this then? There was another study that was just released last year that got absolutely no press whatsoever, called the KEEPS study, K-E-E-P-S, which is the Kronos Early Estrogen Prevention Study. It showed that hormone replacement did show benefit in women in the early menopause. But this led to the recommendation that women can be placed on hormone replacement at a low dose to kind of help them with their symptoms, preferably for about 5 years or so, until they're tapered down to their most lowest effective dose or off. So now the current recommendations are, if you currently have a history of blood clot or or DVT, you've had a heart attack or heart event, or you've had an estrogen-related cancer like breast cancer, liver disease, or undiagnosed uterine bleeding, you shouldn't take hormone therapy. That's pretty straight. But if you're healthy, it's recommended that the use of hormone therapy be limited to the treatment of the perimenopause, roughly that 45 to 55, 59 range, for the menopausal symptoms and for the treatment and prevention of osteoporosis. Hormone therapy is not recommended for the prevention of other chronic health conditions such as heart disease or prevention of colon cancer. And the reason that was in there is because one of the things that came out in the Women's Health Initiative is they found that women who were on hormone replacement greater than 5 years, actually their risk of colon cancer went down. But it didn't really make hormone replacement, they didn't really say, well, I'm taking my hormones to prevent colon cancer. It's not really an indication to prevent colon cancer. That was just one of the findings that they had. And then the lowest effective dose for the shortest amount of time. They also found that, and let's see, did I put it on this slide? Women say, well, I don't want breast cancer. Estrogen replacement alone, so a hysterectomy woman who is on estrogen alone, does not have an increased risk of breast cancer. It seems to be the combination of the estrogen and progesterone together which showed the increased risk of breast cancer. Now, what's that increased risk? Okay, your lifetime risk of just being a woman of developing breast cancer, and depending on who you talk to, but it's either 1 in 9 or 1 in 8, so about 1 in 9, about 11% risk. Your increased risk by going on hormone replacement is about 8 in 10,000. So statistically, yes, there is an increased risk of breast cancer in combination hormone replacement. What's that increased risk? 8 in 10,000. So pretty small. So that's why there's a little bit of misinformation out there. It depends on if you're an optimist or a pessimist. You know, the pessimists are going to say, you got an increased risk of breast cancer. The optimist says, well, it's only 8 in 10,000. So what are your other options? medications such as some antidepressants, venlafaxine is one, it's called Effexor, Pristiq is another name for it. Seems to help with the hot flushing and the menopausal symptoms that go along with the perimenopause. Anti-seizure gabapentin is another one. It seems to help with the sleep, and it seems to help with some of the symptoms like that. Moisturizers and lubricants, the women that complain about the vaginal dryness. There are lubricants out there or vaginal moisturizers that seem to help with the pain that's associated. Botanical products, you know, it seems like green tea does everything, but green tea and tinctures and oils, these are more supplements. These aren't drugs, so they don't fall into the guidelines of the FDA, the Food and Drug Administration. And just because it says natural, it doesn't mean that it can't interact with other medications. And a classic example of that is something like St. John's wort, or I'm trying to think of some others, but St. John's wort's the one that comes to mind right away. That just because it says it's natural doesn't mean that it won't interfere with other medications or that it's automatically safe. Some of these medicines can be, at certain doses, if you have problems with your liver or your kidneys, can exacerbate these problems. This is a big thing that these women come in and ask me about a lot, and that is the bioidentical hormones. The women come in and say, oh, I want the natural hormones. I don't want any of that fake stuff, or I don't want any of that horse stuff. I want natural hormones. Okay, well, bioidentical hormones, that's a marketing term. They used to call it natural, but then they said they couldn't do natural because the only thing that's natural is your own ovaries. So now they call it bioidentical. Okay, they're all bioidentical. If they hit the receptor, then they're close enough. That's it. So it's a marketing term, not a scientific term. And they're manufactured from plants, and they're compounded by a pharmacist based on instructions from a healthcare provider. They're not approved by the FDA, and there's no evidence that bioidentical hormones are any more effective or any safer than standard hormone therapy. And they carry the same risks as standard hormone therapy because they go, well, I just want natural hormones because I don't want those things you give me because, you know, that might give me cancer. They all carry the same risk. So I spent a lot of time trying to talk about natural hormones or bioidentical hormones. They go, well, I get faxes every week from the compounding pharmacies saying, well, I took this spit test and I spit into this little tube and they gave me a number and told me I was low on this and low on this and low on this and that I need to take this medicine. And the thing about the salivary test is that your saliva is just an ultrafiltrate of your blood, and it's not a true representation of what is going on in your blood. And if anything, it's the free levels of the hormones, not the bound levels that would be bound to your plasma and something called steroid hormone binding globulin. So the saliva test or the spit test that they do is really pointless. But there's compounding pharmacies are still doing it. And it's just a way for them to, I don't know, this is my bias here, it's just a way for them to steer you towards their compounded products that they manufacture. So what do I do? So the decision to take hormone therapies depends on many factors, involves balancing individual risks and benefits, like your history, and things like your lifestyle, sedentary lifestyle, as opposed to a more active lifestyle. If you choose to take hormone therapy, regular follow-up is important because your needs change and your risks change and benefits change over time. And that's where the whole thing of annual exam and talking about this every year and seeing how are you doing on your hormones. Do you think we could come down on them? Do you want to try coming off of them? And a discussion that we have every year, all right? And then discuss any new symptoms, like, oh yeah, ever since I started these hormones, my legs really ache, or now I'm really tender in my breasts, or something like that. These are things that we need to bring up. And have y'all seen that commercial of the woman that's in the restaurant and she's like grilling the waiter, like, what's in your salad? What's in the dressing? How many calories is that? Everything. And it shows her in the gynecologist's office and they go, you got any questions? And she goes, nope. So I mean, it's awkward. I mean, and that's why I like to talk about things either with new patients. We sit down and we talk, and I say, I tell them not to get you undressed right away, just because it's just difficult. First time you meet somebody and they're sitting there wearing a paper towel. I mean, it's awkward. It's awkward for me, and I know it's awkward for her. So we usually wind up talking a little bit. And for annual exam, we may come in, do their exam, and say, you got any questions, and then let them get redressed and kind of compose themselves, and then we can come back and sit down and talk about things. And this is what we discuss: any new symptoms, how well your therapy is working, and report any side effects, especially if you're having problems, right away. That's it. So this is time for questions now, and I don't know how specific y'all want to be. So sure, let me just, yes ma'am. Sure. Well, the question is, say if you have a grandmother that had breast cancer and they had double mastectomy, how does that affect her? And that's a great question because women want to know that too. The real risk, especially about hereditary breast cancer, are women who are diagnosed under age 40. So it all depends on how old she was when she was diagnosed, and the type of breast cancer that she had. I mean, October's Breast Cancer Awareness Month. I knew I was going to get some breast cancer questions, and so and that's what it depends on. So this is one of those things where we take in a case by case basis, and one of the things I didn't put on the slide was that when I said that estrogen alone does not increase your risk of breast cancer, women are kind of horrified by that because they've heard so long. So I think that answer is a little skewed in that women who are on hormone replacement tend to make their annual exams, tend to get their mammograms, tend to do their breast self-examination. So for something like that for you would be, I think that, and I don't know all the details, but just right off top, that I think that just because your grandmother had breast cancer doesn't mean that you can't take hormones. But the important thing would be that you get your annual exam, do your breast self-examination, and get regular mammograms. And we'll go from there.
We hope you enjoyed this edition of Health First with Dr. John Wideman of CPC OBGYN. If you would like more information on this Health First show or any of our other shows, feel free to contact us at 256-737-2600 or visit us online at crmchospital.com.